Healthcare consumers, providers, creators, and advocates. Health and wellness should be everyone's top priority, and it's a dynamic topic, complex and sensitive to a vast array of factors from a local to an international scale. The healthcare industry is now at the forefront of everyday life and hopefully on the cusp of a renaissance. We're glad you've joined us for this series that explores the ideas shaping healthcare. I'm Minta Ferguson, healthcare architect and director of the Strategic Facility Planning Group, McMillan Pasden Smith Advisors. And this is Ideas Shaping Healthcare.
Our guest on the show today is Dr. Karen Lommel. Dr. Lommel is the Robert A. Jolly Jr. Endowed Chair for Psychiatry and Community Health, as well as the Behavioral Health Service Line Chair at Prisma Health. She is also an attending physician in the departments of emergency medicine and adult and child psychiatry, and she trains the next generation of physicians as a professor at the University of South Carolina School of Medicine, Greenville. We're here to talk about decreasing the stigma of behavioral health through design, a topic I know is near and dear to your heart, Dr. Lommel. Mental Health America says that 46% of Americans will meet the criteria for a diagnosable mental health condition sometime in their life. With statistics like that, it seems really important to make sure mental health patients don't feel like second-class citizens compared to their medical patient counterparts. And that's what we're here to talk about today. But before we dig into today's topic, can you tell our listeners a little bit about yourself, Dr. Lommel?
I've been in Greenville with Prisma Health, previously GHS, since 2016, and have been the chair of the department since 2018. And as you mentioned, Heather, I do continue to practice clinically as a child psychiatrist, an adult psychiatrist, and an emergency physician. So I'm very excited to talk about this today. Have been working on several different projects over the past 9 years here, actually, from dating back to 2017, about 2018, when we designed one of our first areas for behavioral health services in the ED here at Greenville Memorial.
And we do have two co-hosts for the episode today. First of all, we have Minta Ferguson. Minta, can you please introduce yourself to our listeners?
Thanks, Heather. So I am with McMillan Pasden Smith. I lead our advisory services team out of the Charlotte studio. And we work across healthcare pretty in depth with the design teams.
And I am Heather Hayes. I am a senior advisor with McMillan Pasden Smith advisory team. In that role, I help our clients in pre-design to fine-tune their strategies and ensure they have the right location, right services, and that their facility is right size. Prior to coming to MPS, I was a hospital administrator specializing in strategy and market development, including time as Dr. Lommel's coworker at Prisma Health, as well as a decade at Wake Forest Baptist Health. Next, I want to talk about what decreasing the stigma of behavioral health means to you. And I thought maybe we should just start by having you define for our audience what stigma itself means in this context.
Well, you set it up nicely, Heather, when you said on your statement about it's very important to make sure mental health patients don't feel like second-class citizens compared to their medical patient counterparts. That really summed it up very well, is that the stigma of seeking services, seeking psychiatric services or services for addiction, it prevents people like, oh, that shouldn't be something I go to. But you'd be fine going to see your primary care doctor for high blood pressure. So really going to see somebody for depression or anxiety should be the same. Going to the hospital to be admitted to receive psychiatric services should be the same as going to be admitted to the hospital with chest pain. So really making it level across the board that it's okay to seek services for mental and physical health equally.
So now that we've sort of level set on what stigma is, can you talk to us about the types of things that have the potential to reduce stigma in the care environment?
You start with aesthetics. So really, what does it look like around you? I mean, historically, we think of psychiatric hospitals or clinics where we see psychiatric services as being darker, kind of older, antiquated. And really what we're looking at is how do we make it brighter, more natural light, calming colors, open, a lot of big windows or areas to look outside for the natural environment. But also for circadian rhythms or ways to keep your sleep cycles regulated, especially in the hospital. That is very important, medical side and the psychiatric side. So making sure that we have lighting that is greater during the day and then calmer and more reflective of evening at night to keep people in that same frame. So I think also patient experience. What does it feel like when you're on those units? So really what we're trying to do is make sure that our staff, our team members are interacting even more with patients in the activity spaces, the group rooms, having dining rooms on the units with calming colors, local artwork, just more space for patients to walk around and engage with each other and with the staff. And then making sure patients have their some control over their space. So there are quiet rooms on the units, making sure that if the regular part of the milieu is too loud or too stimulating, going to a quiet room, but still being close to the rest of the patients to engage in treatment in that way.
Thinking about making an impact in this area, what would be signs of success that we're actually moving the needle on reducing stigma for these patients?
I think actually building facilities in areas that meet these qualifications, and we have seen that already with a couple of our units. So EPOD in Greenville Memorial, and then the most recently opened Behavioral Health Emergency Care Unit in Oconee. So really, we're showing that, hey, we are doing it. We are making sure that we have natural light in these spaces, especially in an emergency department where that's not part of the requirements, but we have that for our patients. So really, are we being successful in saying, you know what, we need to be caring for our patients in a different way? So I think the success is actually putting money where your mouth is. So we actually,
And they deserve that.
Yes, absolutely.
So switching gears a little bit, one of the things that always comes up when we talk about this patient population is how do you balance safety and security with the desire for that more therapeutic and healing environment that you just described for behavioral health patients? How do we achieve both goals?
Safety and security. I mean, we want to make sure that we have the appropriate ligature resistant hardware. So the doors, the faucets, but also making them aesthetically pleasing. So it's not looking like a prison cell, like some older, I guess, special behavioral health designs were even 5, 6 years ago. Now they are saying, wait a minute, we need it to look a little bit better so that we are not stigmatizing this space with a very sterile looking environment. So making sure security, doors are still, we need to have locked doors, but yet how do you come into this space? It's very welcoming. As soon as you walk through those doors, they are locked, but it is very welcoming. Again, open area, the hallways are bright. On one of the new hospital will have a 3-season porch on each unit. So really making sure that we have found that balance.
How do you balance when it comes to like the policy and procedure side of things as well, Dr. Lommel? How do you sort of weave both of those goals into policy and procedure?
I mean, we do that through making sure the staff, in terms of the patient enters the space, what is the first step? So the design of the space, when you walk in, we have the area right to the right. I'm looking at the design of the floor design. You walk in and there's a space there where we do the assessment. So you welcome the patient and you follow the policies and procedures to make sure that all personal belongings are kept in a safe space, but also that patients maybe do not have something that they brought in, not knowing they had something on them, a lighter, pocket knife, something like that. So we manage the policies with the design by making sure we walk the patient through the space, making sure the staff know everything that's supposed to happen when the patient comes on the unit, and making sure that we ensure safety for the patients and others.
Dr. Lommel, I want to talk about a couple of different behavioral health projects that Prisma has either recently launched or in the works that have this goal of decreasing stigma in mind as part of their design. But before we jump into the first facility, could you describe for our audience the behavioral health continuum of care and what that is?
Well, so we have patients that need different levels of care depending on where they are. If it's a crisis, then we want patients to go to the emergency department. And again, if they're in imminent danger or if there's a possible medical condition associated with, say, for example, an attempt to end their lives or a suicide attempt, we need to make sure that in the emergency department, We have the medical side, but then also the psychiatric specific spaces. So that's one element of the continuum. We also have our general outpatient clinics. So where you maybe go see a therapist once a month, every other week, whatever it may be. The psychiatrist may be there as well. So that's a general clinic setting where you go for your half an hour appointment. But then you also have day treatment programs. So we've just expanded our partial hospitalization or PHP program and our intensive outpatient program or IOP, which are considered day treatment programs. So the IOP is 3 days a week, about half a day, and the PHP is a little bit more intensive, so 5 days a week. That may be a patient who needs a little bit more than just the outpatient clinics type of care, or even if they're seen in the emergency department and the crisis is addressed, then we can have patients go to that day treatment program if they do not need even the highest level of care inpatient. So going to the hospital, staying 24/7 on the inpatient side or the hospital side is the highest level of care. So that's an example of the continuum that we have for services.
So a couple of these facilities may actually touch on different points in that continuum. So the first one I'd like to discuss is the Behavioral Health and Wellness Pavilion that's at the Greenville Memorial Campus. And the upfit here was designed by our MPS team. And there's different services located here, but one of the intensive outpatient and that partial hospitalization that you mentioned. And what does this population, the intensive outpatient and the partial hospitalization, what do they need from a clinical perspective and from a design standpoint?
From a clinical standpoint, we, of course, need it to be accessible. So we need ample parking because patients, again, are coming and going throughout the day. For IOP, we have 2 sessions per day. So we need to make sure that we have enough space for patients to come in to the facility. And then the other part is keeping the adolescent patients have a separate entrance from the adult patients. So those are some just initial design considerations for when a patient enters this space. For the adult side, making sure that we have several of the day treatment rooms. The majority of the care takes place in a large group therapy room, but also having space for like a kitchenette because we are required to provide lunch for patients to attend the partial hospitalization program. But then for our IOP program, we also have snacks and coffee and things like that allowed. So we need to make sure the spaces are readily accessible, separate enough for privacy and for sound control, but also having an assessment space where when the patients come in, they are seen by our assessment team, includes vital signs. And so the medical side of things we initially consider as well. But then also when they're discharged from the program, having that assessment space separate so that they have privacy and can walk through the next steps of their care with the nurse who's doing the final discharge process. Other design considerations. So on the adolescent side, and we're going to go into this in a little bit later, but we have the eating disorders program. And so we have a kitchenette and we have actually just hired a dietitian. So we have special requirements for our eating disorder population. And then our general adolescent population, making sure we have space that's fun with fun posters that describe what is it like to be a healthy teenager? What are some things that you need to do with this program to be successful? So those are some examples. The mother-baby program, we can talk about that here too. There are some very specific design elements to that program. So we're fortunate in that we had a space that was really, it took a lot to upfit that, but it was one space in the Employee Services Center, which is actually I'm sitting in right now, which is the pavilion, where it was our old SIM center. So it had a separate vestibule and an area back there that we could keep separate from everyone else. So for safety reasons, we have separate access for the mother-baby program. Moms will bring their babies up to a year of age to this program. And moms will work in one area in a large group therapy room, but then have constant view of their infant if they are in the room next door. So we call it the infant lounge. It actually there's a large window between the mother's therapy group therapy room and the infant lounge. So sometimes the moms will actually go in, have their babies, pick up their babies, bring them into the therapy session with them, or bring them back to the lounge so they can focus on their own therapy, but yet having the baby right there with them. And the vestibule that for the SIM Center is now the initial access space with a separate secure access point.
Nice that it gives them the flexibility to, have baby or kind of let baby be somewhere else while they focus. I think that's fabulous.
Definitely.
And one thing I'm thinking of as you're describing that too, and we're talking about decreasing stigma, you would think nothing of a mom bringing their infant to a medical appointment. That's happens all day, every day. So you're trying to create that corollary, in the psychiatric environment that, it's fine. You can, bring your child with you.
That's a good point. Absolutely.
So I would like to touch on the adolescent eating disorders program a little bit more. And what are the unique characteristics for that program, for the design and what it is that they're going through?
So we have not opened that program quite yet.
Oh,
We are in the process of finalizing the hiring because it requires an area of expertise for the therapist, the psychiatrist, which we have Drs. Epitelli and Kun-hee Lee, our PA, who've been working with our eating disorders population in the Children's Hospital now for several years. Also making sure that our adolescent medicine team members are part of the program. So Dr. Guyton has been heavily involved with the planning of this. And as I mentioned earlier, a dietitian is essential. So in this space, we converted one area, it used to be an office cubicle space that we converted into the kitchenette. So it's bigger on the adolescent side because we're really hoping to work with our adolescent patients with eating disorders in the outpatient space so they can go home at night instead of having them in the children's hospital where we may not have everything we need accessible. But also hoping to partner with the Ronald McDonald House for maybe patients who are coming from farther away. So anywhere Midlands to the coast, if we have patients that attend the partial hospitalization program, we can have families nearby as well.
Maybe let's shift gears into how did you find this space and think about the transformation of it, right? So this is an existing facility, and it was underutilized by the organization. How did you come to find it and say this is a good place? This will suit the needs to renovate and transform it into behavioral health and wellness services?
Well, I love to renovate both my own home, but also other spaces. So, the joke was I would like to be an architect one day, and even talk to the Clemson architect director, maybe joining their team someday.
Good company right here.
Right. So, no, I think walking into the ESC building, so Employee Services Center is what this building was. So 24,000 square feet of very underutilized space. When I joined in 2016, this is actually where I had my orientation in one of the very large rooms, and Heather probably remembers that too. And then when we moved to online orientation and onboarding, really didn't use this space. I would say probably on a given day, there are probably, I don't know, maybe 15 people in the entire building. So very underutilized. Walking in the space, it was a little vintage 1980s kind of feel to it. So looking at it, thinking, but there's so much more that this could be. And just immediately thinking the adolescents could go in that side door to the front on the left, and then the main door for our Grove Road Clinic and the day treatment program through this same space is perfect. It just made sense. And the rooms were already large group rooms. So it wasn't, that part of the renovation was very minimal, to be honest. And then seeing how we can convert some of the spaces to shared workrooms instead of having separate offices. So that has worked very well. And then just really converted a couple of the tiny exam rooms into a larger workspace with shared office area, docking stations, all that. So it was pretty natural. It really seemed to take shape pretty quickly.
Yeah, you gave it some new life. So you took something old and made it new again. And healthcare is changing pretty fast. And of course, COVID changed how we deliver healthcare services. But what are you doing in behavioral health that's innovative in healthcare delivery? Are you doing telehealth? What does that look like in this facility?
Telehealth, specifically telepsychiatry, has really been used since the late 1990s. So I would say when I was at University of Kentucky before coming here, we were doing telepsych using these T1 lines to the rural areas of Kentucky. So coming here was there was a tremendous opportunity to increase that. So even as far back as 2017/2018, around there, we started using telepsych from our main hospital, so doing the consultations to the other hospitals, so Baptist Easley, Greer, et cetera, on the medical side, so delivering psychiatric care through telehealth there, but also from the ED, from our main ED to the other community EDs. So we've been using it in the hospital setting. As you mentioned, COVID really opened the door to many other opportunities. So it was the silver lining of COVID. That allowed us to actually deliver care to patients in their homes. So we were not able to do that before before COVID. So it really helped us address the social determinants of health. So sometimes we would see patients in their homes, and say we had a patient who maybe has asthma and severe anxiety or ADHD. We're seeing them, and as they're sitting there on their phone or on their computer, you're looking around the room and you can actually see what their environment looks like. And in some cases, we pick up, my gosh, there's black mold on the wall, and this family's been struggling with the landlord to get them to address it. And so seeing that and seeing how that contributes to the physical and mental health of this patient, we can reach out to our medical legal partnership and have them address that. So success stories in addressing things indirectly and directly related to mental health through telepsych services.
You have the telepsych, you're adding the adolescent eating disorders program in the facility. Is there anything else on the horizon for the pavilion? Any other programs you plan on adding?
We are actually planning to add a geriatric day treatment program, shooting for October. The first week of October as our opening date. So Dr. Nagar is our geriatric psychiatrist. She's been up in Greer, really spearheaded the consultation services, again, using telepsych, to the Woodlands and other skilled nursing facilities in the area. So she has a passion, of course, for a geriatric population, and will be starting the day treatment program on Tuesdays and Thursdays here in the pavilion in October. It helps with socialization, working on a program for transportation as well. So that's something we're very excited about.
Yeah, and I know we've done a couple different geriatric programs as well in terms of design, and they have their own unique kind of design features and things that just come with aging too, with eyesights and contrast and kind of misinterpreting colors and things and patterns on floors and walls and things like that. So I'm sure there's a lot you guys plan on doing for that program through design.
And with the new hospital, we actually considered quite a bit of those elements you mentioned in the design of our geriatric unit there.
Dr. Lommel, I've known you for a long time, and I know you're a firm believer that behavioral health services can be profitable. And in fact, when we talk about stigma, there's almost a stigma against the service line sometimes, that there's a perception that it can't be profitable. So what have you done differently with these programs to ensure their financial viability?
I am going to jump in, and I know that if you look at the P&L sheet or all that, for, as you mentioned, often the behavioral health is not the more profitable line of an organization, but also making sure that we keep in mind the downstream effects, the cost-saving effects of making sure our patients are not staying in the emergency department when really they need to be in either a day treatment program or in the hospital. So really maximizing where they need to be in the downstream savings there. I think with the day treatment program, really the benefit is that we are able to care for more people in a setting that is correct for them, but also we are utilizing fewer team members to address more patients at the same time. And that's one way to look at it.
Dr. Lommel, a lot of times we talk about behavioral health patients and making sure they're getting resources in the right place. And a lot of this can come to play through law enforcement and crisis stabilization. So there's a statistic that I saw recently that law enforcement spends an average of 3 hours transferring a patient to a medical facility versus 37 minutes transferring them to a jail or a detention center. So I want to shift gears a little bit and talk about behavioral health in the emergency care setting, so different place on the continuum. And some of our listeners may be familiar with an empath unit. So that's emergency psychiatric assessment, treatment, and healing. And the goal of these units is to evaluate patients in a therapeutic and less restrictive environment than we've seen in other cases, like you mentioned. You describe these as behavioral health emergency care units, and they're a little bit different. Can you describe the differences between the two models?
When the state of South Carolina launched the grant proposal request for the empath unit, so $45 million for the crisis units or empath units across the state. There are many conversations of how the empath unit it's a great model. The idea of getting the right care for the right patients as soon as possible upon entry to the emergency department is the goal. It remains the same. So BHEC, so we call them our BHEC, no longer have DHEC, so we're okay with using BHEC, but our behavioral health emergency care units are essentially the same. So they're empath-like. So the idea is the same, to get psychiatric care to these patients who presented as a psychiatric or substance use related crisis, the right care. The empath units are primarily recliners in an area, a shared space, without separate rooms for patients who may need decreased stimuli or may have issues with aggression, or if extreme psychosis is present, it's really hard for them to be right next to somebody else who may be psychotic as well, or struggling with those. So having rooms, a quiet room or a patient room, sometimes it takes more than 24 hours to find an inpatient bed for some of our patients. So having a separate space where there is a bed available and not just the recliners in the shared space is essential. But also, I think since COVID, and many of the emergency physicians who've been on these calls has also said that, since COVID, we have seen quite a bit more aggression presenting to the emergency department. So patients with aggression, and in the recliner specific areas, that doesn't go well. But we still need to have our patients who are experiencing a psychiatric crisis in a space away from the rest of the ED for their safety and for the right care for them as well. So they aren't that different in the overall principle. It's just having a space with recliners and separate rooms versus just all recliners. And probably the acuity of patients that we care for is higher than, I think, when the empath model was initially developed. And I know it's spreading across the nation, but there are also some things we have to work through with the challenges of those units.
I know there's at least 3 units that Prisma has, and I was curious if you have anything about these that you want to highlight in terms of their design and ability to support patients in that way. So the first one is the ePod, and that's at Greenville Memorial. And I believe it opened in 2020, and MPS designed that, and it was converted to medical for a little bit during COVID. So it has some flexibility. Can you discuss the design of that to be able to do that?
I might back up a little bit. So with Prisma overall, including the Midlands, we actually have several units they're not empath units or BHECs in current state. So they've been in operation, as you mentioned, ePod since 2020. And actually in the Midlands, we have Orange Zone and Blue Zone. There are also separate psychiatric care areas within the EDs, similar to ePod. So separate rooms. So one thing with ePod is we have 13 individual rooms with all behavioral health specific hardware. So the doors, the faucets, etc. So we designed that space to convert if needed. So the medical gases, suction, all that is behind a separate space, a ligature resistant cover, but then also cabinets with telemetry capabilities. So if we convert, we have to convert the entire unit to medical, which again was used for a brief period of time in early COVID upon opening, but has been open as a psychiatric space since then. So it really hasn't converted back. So that's one element of that, and having it again separate. Let me back up. There are 5 recliners in EPOD as well. So 13 rooms with 5 recliners, but the 13 rooms are used primarily. Recliners are for space if we need it for patients who are being discharged. We can use that as well. There's also a day room. We brought the unit all the way to the front of the hospital, so natural light is available for patients in that day room in EPOD. That was essential. Same with the Coney. There's actually a window to the outside by the ambulance bay that allows natural light as well.
Do any of these types of units play a role in that ability to, I would say, gracefully transfer a patient, like for law enforcement, to transfer a patient into a healthcare environment easier than, say, like when they're transferring them to a detention center? Talking about, how do we make sure we're getting or increasing accessibility, decreasing challenges and roadblocks to be able to get them where they need to be and get the right resources? Do these units help in that regard?
They do, yes. So I think the big part is if a law enforcement or EMS arrives with patients, we have a process for medical clearance by the emergency medicine team, and then expediting back to the area where they can receive the care. So, for example, EPOD or the BHEC in Oconee, and soon to be BHEC in Toomey.
You also have a new inpatient psychiatric hospital that's currently in design with Canon. Can you talk to us a little bit more about that project and any unique design features that you're incorporating into it to help reduce stigma? I think, it's a brand new facility, so you probably have lots of ideas coming to fruition through it.
This has been in the making for about a decade. As we have we've had different versions, and Heather probably remembers this over time, is that there's initially a JV, and then we joint venture plan, but then we had our own. So we built a 65-bed or designed a 65-bed hospital, but for the right reasons in 2019, when Mr. O'Hall, our CEO, came in and said, we really need to put a hold on capital freeze and focus on our team members. So $140 million went into our care team. And that we would have opened a new hospital without anybody to work in it. And that actually has happened across the country, where people have designed these beautiful facilities ready to open, but they don't have the staff to staff it. So then we're not able to open it. But moving to this exciting building, because we broke ground, the walls are going up, steel is in the ground here within the next week or two. So we are moving forward. It is very, very exciting. So the new hospital will be located on Old Easley Bridge Road, so in Easley, so Pickens County, 8 miles from Greenville Memorial and 7 miles from Baptist Easley Hospital. So really between 2 of our key medical facilities here in the upstate. It'll be 112 beds. Currently, we are licensed for 65 beds at Marshall Pickens, and only 10 of them are for children. So the new hospital will be a total of 40 beds for kids. So 2 20-bed units for kids, and then 3 24-bed units. So some of the unique features here, as we talked about earlier, natural light. So it's a very beautiful 46-acre wooded piece of property that we have, as I mentioned, in Pickens County. And the patient rooms are primarily along the back of the facility, facing the wooded the wooded property. So that is one element. The other part I mentioned earlier is the 3-season porches. So each unit has a 3-season porch with a nice mesh that we will allow the fresh air to come through, but also sunlight, etc. A few of the really unique design features of this hospital include the courtyards. The main courtyard is in the center of the building, so surrounded by the building itself. And the topography of the property allows for a tiered courtyard. So we can access the courtyard from the lower level, but also from the main level as well. And we'll have different types of vegetation there, but also covering for shade for patients. We are in South Carolina, so it's pretty sunny. And then other spaces for patients to sit and relax and enjoy time with each other outside. The other part is the courtyard for the adolescents, basketball hoops and other kid-friendly apparatus up there. And then on the adult side, we'll have that more for the adult population with plenty of places to sit with, vegetation and other courtyard elements there as well. I think the other, maybe I might mention two other neat design features if I can, if that's okay. So you talked about law enforcement and importance of making it more convenient for our team members and colleagues with law enforcement to bring patients to our facility. So this new space will have an assessment area with a Sally port, so an EMS garage. So we can have law enforcement or an ambulance, two at a time actually, come in, and we have a garage door and then a separate entrance to the assessment space, separate side for children and adolescents and another side for the adults. So that's one unique feature, something we do not have at Marshall Pickens now. Very few hospitals have that in our area or in the state, actually. And the other part is the Wellness Center. So we will be received a donation from the Sargent Foundation for $1 million for the Sargent Wilson Wellness Center. It's a combination of a gym, but also a community space. So during daytime hours, or we will have our patients using the half-court basketball space, but then the doors open to a patio area. So if we have events, both for patients, but also for family members or loved ones who want to come in and learn more about psychiatric disorders or how to support their loved one, we hope to bring in NAMI, Mental Health America, FAVOR, so Faces and Voices of Recovery, and really work with our community partners to help educate our patients and their families.
Well, that's a great segue to my next question, Dr. Lommel, because I feel like part of reducing the stigma is considering how the family members and loved ones and caregivers who support behavioral health patients might be new to this journey and may need assistance navigating or even just having a basic understanding of expectations. How have you factored that into the design of these facilities?
You mentioned the Sargent Wilson Wellness Center. So that is really one of the key features of the design. The nice part is on the main level. So entering the facility through the lobby, it is really accessible to patients and family or patients from the units, but also for families from the lobby. So again, bringing people together in this space that is very welcoming, a lot of natural light, open area with the doors that are open to the patio, really was a big part of the design. And Stephanie Vito was the architect who's worked with us on this. On the units, we have space for when patients arrive with a loved one, or if we have family meetings, we have plenty of consultation rooms and separate spaces for privacy for our team members. It can be the social worker, the caseworker, our providers, our psychiatrists, or residents to meet with the families in a private space, a little bit away from the unit, but in close to the entrance.
How can our listeners help with this goal of reducing the stigma for behavioral health services?
I think advocating and speaking about it when perhaps like I'm not in the room. So that's really what I ask, even with my colleagues here, the other chairs and for other departments where maybe people are in a meeting where they are bringing up the topic of behavioral health and I'm not there. They stand up and go, wait a minute. I heard Karen say something about this, and then they mention it on our behalf. So I would say people expect me to talk about it and be excited about it. But when others are also supportive and support the cause, that's really what we need, to be honest.
We will be your ambassadors going forward, Dr. Lommel.
Thank you.
So Heather, in review, I'm thinking through a couple of different things that I took away from our conversation. The first one is because I'm an architect and I'm always focused on form follows function is a little bit more about like the intent and purpose of specific spaces and their role in healing and therapy, but also the safety and security aspect. So that was one big takeaway for me. What was your big one?
I think I just, having worked in hospitals for so long, I have a heart for this patient population. So for me, it was just exciting to hear these like very tangible improvements from, the physical environments that I'm used to seeing for this patient population. So, at several points, I just wanted to say yes, because it's a win. It's like it's a huge win for that patient population and everyone that loves and cares for them. So, it's exciting to see that service line moving in this exciting direction.
Yeah, I like the 3-season porches and the courtyards and windows and spaces to get light in, and just the talk of like materials and even playing on people's senses and how that relates to their journey.